Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. Welcome to another episode. Today I'm with Dr. Hayley Vatcher. She is an oral medicine specialist practicing in South Carolina and Charleston. Hayley, thank you for joining us on the podcast again.
Thank you, Grant. I'm happy to be here once again.
Yeah, we've had some great kind of oral medicine topics that are really pertinent to oral surgery, and I think there's a lot of great crossovers. So always good info and good talking to you. A couple quick just announcements for our listeners. So we're doing multiple series of things. One is a book club, and we're kind of gonna every other month or so review a book and discuss it. Some people have reached out, they want to know the book ahead of time. So for those interested that want to prepare and read a little bit, my brother, who's an oral surgeon, we're going to be reviewing this book called The Dichotomy of Leadership. It's by Jocko Willink and Leif Babin, Navy SEAL. Just talk about leadership principles. It's a lot of applicable stuff for what we do in our practice and how we're leaders. And then also too, I have a kind of a recent blog I started, everydayOralSurgery.blog. So usually once a day or every other day, I'll put a post on there of some type of oral surgery topic that's kind of not your usual topic that isn't talked about much, some interesting stuff. So I always appreciate feedback. I love it for those readers out there who want to read something quick and short and kind of a brain teaser / food for thought. Jump on there and comment, and I'll comment back, and maybe we can have a good discussion. All right. Thank you for letting me get those announcements out of the way. So today we were talking a little bit about odontalgia and some of the ways that, when it's not very easy to diagnose. We get a lot of these in oral surgery, right? Like a lot of our practicing GPs and things, they'll see patients, they don't know where pain's coming from, and they'll just be like, okay, I've sent them to so-and-so. It's not a tooth situation, or maybe it is, but I have no idea where it's come from. In the end, they just say, send it to the oral surgeon. He seems to be the most knowledgeable guy. Maybe he can figure this out. And most of us, when we see that on our schedule, we kind of cringe and we're like, oh, great, another situation where what do you expect me to do? I don't know what's going on here either. So I think this will be a good topic for us to delve into. Can you kick us off with kind of how we define this?
Yeah, absolutely, Grant. One of the terms, atypical odontalgia, is what the podcast will be on today, but there is an updated term that it is now called, which it's a mouthful, so I'm going to be referring to it still on the podcast as atypical odontalgia, which, atypical, right? A not typical pain. So not from a typical pain from a tooth like periodontal disease or an abscess or infection or a cracked tooth or something that has a cavity, any of these things at all whatsoever. It's more of an atypical pain, which we'll get into later. And then odont means tooth algia pain, right? So atypical tooth pain. It's also known as phantom tooth pain. And the more updated term is now either persistent idiopathic dentoalveolar pain or persistent dentoalveolar pain disorder. And that's what the international classification of orofacial pain is now calling it, PIDP or PDPD. And so that's where, again, the classification has come in back in 2020, and it has updated this disorder. What they define it as is a chronic non-odontogenic pain, typically unilateral condition that presents either an area of a tooth or the extraction site or that dentoalveolar site, but there usually is no identifiable dental cause. And patients will describe it kind of any type of way. They use pain characteristics like dull, aching, throbbing, kind of can be even neuropathic, like sharp shooting. But typically it's a constant pain that can last for months or even years. And you have to have it be more than 2 hours of pain in 24 hours, more than 3 months to kind of be considered this. Typically it does not respond to conventional dental treatment. So endodontic therapy won't help it. Extraction won't help it. filling or crown. And so it typically will lead to a lot of unnecessary procedures. And clinically, the pain is very localized, again, usually unilateral, confined to that dentoalveolar region without any sign of infection, inflammation, or any pathology on the radiograph. And so that's why oral surgery and then oral medicine probably gets a lot of these patients, because both the dentist and the endodontist has ruled out odontogenic origin. And so, of course, they get kind of put to us in oral surgery, right? Grants, I know you guys get a lot of these too. I find that it's rising, and something that you really have to dive into a little bit more, rather than just hearing the patient say they're in pain and then just going for the root canal or going for the extraction. You want to do a lot of like sensory testing and kind of get their pain history on it, because that might be leading you to this neuropathic pain diagnosis instead of a typical dental pain.
So for the patient that's referred to us with this kind of idiopathic pain, dentoalveolar pain, I mean, what's typical presentation? I mean, at least what I see is a patient who's saying, "Oh yeah, some of my teeth hurt," or it's not usually like this certain one tooth hurts. It's kind of like multiple teeth, and but
Mm-hmm.
we're taking X-rays, everything checks out. Where do you go from there?
So what they'll tell me is, they actually might say one specific tooth, and typically the tooth has had some type of dentistry on it. So it either has had a filling or a crown or a root canal, or has been extracted. And so, of course, the socket is then, causing, that's where they can point to the pain, is like the actual socket or the implant in there. So typically it has had some dentistry on it, but yeah, they can also point to like a section of either the maxilla or the mandible, and it can be a couple of different teeth. So I always ask them, the pain characteristic, current level of pain, average pain level, worst pain level. When did this occur? Kind of make sure it's more than 3 months, although I think obviously it could still happen before that. But we don't really want to treat them with some of our pharmacologic therapies until we kind of have made that known. I'll ask them, of course, has there been any therapies on the tooth? Has there ever been any pathology on the tooth? But yeah, they typically will say it's in one section of either the maxilla or the mandible, and they are able to pinpoint exactly where sometimes. But you want to make sure to rule out sinus, TMD, trigeminal neuralgia, some of these other neuropathic conditions. So I always ask them certain questions on that, like, okay, is it spurred on by any light touch or gust of wind or a cold? And typically for atypical odontalgia, it's not going to be worsened by cold or heat or chewing, although it can be. So that's why it's kind of gets a little bit fuzzy in terms of the diagnosis. Usually the endodontic testing is normal, although sometimes they could have some sensitivity to the cold. But I think that's where you rely on your radiographic findings there. Let's say that someone has kind of convinced me that they do have this. Per the literature, the first line of therapy are these tricyclic antidepressants, right? So nortriptyline, amitriptyline, and then sometimes protriptyline. Or they can do an anticonvulsant, gabapentin, pregabalin, sometimes other type of drugs like duloxetine. That's the first line of therapy per the literature. However, something that I've found in my practice that's a little bit more conservative, localized, and not something that I'm gonna have to check their blood levels and kind of, worry about the side effects of the systemic medicines, is actually botulinum toxin. So Botox has been shown in the literature as well to help with these patients in terms of their pain levels. All, the pharmacologic medicines and the Botox both will decrease pain signals. We can kind of talk about that later in terms of what happens pathophysiologically to these patients that are having atypical odontalgia. But one thing I do offer is a localized Botox treatment around the gum area of the tooth. And it's been shown to be quite effective in the literature and both in my practice. For some reason, I've had 99% success with Botox with my patients. And
Wow.
it's quite amazing. It's I'm kind of tailoring it to see what best works for them, because you have to kind of be careful if you're going to put it in their vestibule, because obviously, the orbicularis oris is right there, or sometimes even like the rhizoris. I don't want to droop their smile at all. But Botox is one of the main treatments that I do for my patients. There's also, cognitive behavioral therapy. That's something that can be done because typically there is an anxiety depression that can come with it. And then one of the newer studies out there has shown a Japanese type of medicine, which is quite interesting. I haven't tried it myself, but Kimisho Yosan, that has been shown to be effective in reducing pain intensity in these patients, particularly those who haven't responded to some of the other therapies like CBT or like some of the anticonvulsants, tricyclic antidepressants, SSRIs, SNRIs sometimes, or Botox. And that's, it's a bunch of herbs and they are delivered in either granules or a tablet using traditional kind of Japanese Campo type medicine. Again, it's just something that I saw in the literature, but I personally haven't tried it myself just because I've had success with getting pharmacotherapy for them. But that's another kind of option that they can do too.
Okay. So usually it's a tooth that's had dentistry on it. And what is the thought there that there's been some type of nerve irritation and that the nerve is kind of irritated or inflamed or has been damaged in some way?
Yeah. Yeah, so this is a type of neuropathic pain condition, and typically for that, it has been nerve damage or nerve dysfunction. However, you can still get atypical odontalgia in a virgin tooth. Most of the time, it is a tooth that has had dentistry. About 65 to 70% of the time, the tooth has had some type of procedure on it, but 30 to 35% of the time, it is a virgin tooth. And what usually happens is, yes, I kind of tell my patients it's like the nerve is short-circuiting. And kind of in layman's terms, I kind of tell them, how our body was created back in evolutionary times? Well, we're not really meant to be doing these things to our teeth, right? We're not really meant to be having a filling. We're not really meant to be doing a root canal. Like these aren't things that like our body years and years, like hundreds of years ago was really meant to have. So to me, what happens is the nerve endings start to short circuit. They kind of freak out because it's kind of like almost like a foreign thing to them. And so they start this pain signaling cascade. And that's what kind of is creating this like short circuiting in the brain, which then goes up through, from the area of the tissue damage or where they've had their procedure. That's where the pain signal gets transmitted to the spinal cord. The spinal cord will then amplify the pain signal to the brain stem. The brain stem will then send it to the actual brain itself, and that's where the brain will then send it to either like the prefrontal cortex, the somatosensory cortex, or even the limbic system. And the limbic system is where we have emotions attached to the pain. And so it kind of gets amplified through all of that process. Then it can even get put back through the descending pathway, and that's what will amplify the signal even more. So again, it's this dysfunction that happens towards the spinal cord that will amplify the pain signal, and it kind of just gets into this rut of where it's the electrical signals are not firing appropriately because of some type of tissue damage or nerve dysfunction. That's kind of what happens with atypical odontalgia, and even as well with persistent idiopathic facial pain, right? They're very much related. And also too, phantom limb pain works in the same way. And that's another thing that I tell my patients because, it's hard for them to believe that their tooth hurts, but it's not a tooth problem, right? And so I kind of tell them, okay, well, another term for this is phantom tooth pain. You probably have heard of phantom limb pain, where the limb is completely gone, but the brain is still signaling to your body that it's still there because there's still being pain transmitted. And they kind of understand a little bit more when I tell them in this way.
Okay. Mm-hmm. And you mentioned we want to try things pharmacological and other types of things before just extracting or doing a root canal. I mean, I've seen patients who have pain and there wasn't a certain thing, causing it, and someone root canaled it and still had pain. And then they came to me and we're like, throw our hands up. Well, I mean, I guess we could extract it. And sometimes they still even have pain. It's very strange because you'd think it was coming from the tooth, but I guess the nerves that are going to the area were more damaged than something inside the tooth. Or like you're saying, there's somewhere in that pathway that is got short circuited or messed up, and even extracting it doesn't solve the problem. Have you noticed that?
Oh yeah, I mean, typically all the patients I've had in my practice, might have had like retreatment of the root canal. They might have again had the tooth extracted, even the tooth next to it extracted, thinking it was like a referred pain. Yeah, they've had a lot of procedures on it, which actually to me worsens it because that's more damage to the tooth, right? And so sometimes doing a treatment on it makes it worse as well, kind of like in trigeminal neuralgia, another neuropathic pain condition. But I do get it's very hard because say someone goes in for a root canal because they're presenting with pulpitis and they do the cold testing, the pulpal testing, and it does come back as kind of abnormal. And maybe they don't have symptomatic atypical periodontitis, but the endodontist wants to treat it anyway. Maybe there's like a crack they're missing, but they don't see it on the CBCT, and then they do the root canal. Hasn't helped at all. They'll wait, while maybe they'll do a retreatment because maybe there's some accessory canals that they missed. I mean, it is a very, very challenging diagnosis, I will say. But yeah, I think typically patients do not get relief with the dental treatments and even can make it worse. So I have a lot of patients who come to me because the endodontist or the oral surgeon or the dentist is thinking it's non-odontogenic, and I really try and convince them, hey, even if you get this tooth out, it might not cure your pain, and then we're back to square one and you lost a tooth, and then got to look at tooth replacement. So I personally would love to try some medication, either topical or Botox. And when I say Botox, you could even do Xeomin and maybe Dysport, but I just meant like the botulinum toxin or a anticonvulsant or tricyclic antidepressant before they do something completely irreversible, right? Because oral medicine is all about doing conservative reversible therapies. And so to me, that would be worth it rather than like taking out a tooth and that you're never going to get back.
So when should we, as the oral surgeon, the endodontist, refer to you? I suppose when maybe there's been something on the tooth, but it looks fine, and we're not really sure what's going on with the pain, and everything checks out. Or when do your people refer to you?
I'd say if someone has more than 3 months of pain in the tooth, and if it's a virgin tooth, they've done the periapical radiograph, it looks completely normal. They've done pulpal testing, they've done percussion testing, palpation testing, and it's just presenting, not something of a typical tooth pain. There's no abscess. All of the probings are normal. If they do translamination, they don't see any cracks or fractures. If everything looks completely normal, that's when they really send it to like the endodontist that I find the dentist does. And then the endodontist will do a CBCT and look really hard for the fractures. And then at that point, it's been way more than 3 months, and so then they kind of send it to me when they've confirmed that there's nothing on the radiograph and that they are maybe presenting more of the dull, constant pain characteristic. One thing that I find is they are in constant pain. It's not really intermittent. They always have some type of, even if it's like a 2 out of 10 or a 1 out of 10, it's always some type of sensation there instead of like an intermediate type of pain.
Sounds good. And then what is your algorithm to say, now I'll try Botox, or how do you know when to start doing these things?
Yeah, so the evidence says that the pharmacotherapies in terms of taking anticonvulsant, tricyclic antidepressant, maybe even SSRI, that's what they say is the first line of therapy. But a lot of my patients are already on some of these SSRIs, SNRIs, and kind of one thing to chat about is there are a lot of comorbidities that are associated with atypical odontalgia, like anxiety, depression, sleep disturbance, fibromyalgia, TMD, chronic headache, chronic widespread pain, and then multiple chemical sensitivities. So sometimes I can't really put them on another type of drug like that. And I do obviously collaborate with like their psych doctors or their pain management doctors or their primary care providers or their neurologist.
Yeah.
But, I don't want, like, maybe they have tried for years to improve their sleep and they're finally on a great amitriptyline dose or trazodone, and I don't really want to add something else that might mess that up, I typically start by offering those type of medicines, but also during the same appointment, I will offer the botulinum toxin because that one, again, is completely localized. Like, I don't have to check for labs. I don't have to worry about the nortriptyline getting more in the blood level that I want to. I don't have to, send for that serum to check for that. I don't have to worry about medication interactions or any polypharmacy because it's not really systemic in that way. Botox stays exactly where you put it, though obviously it does travel up through to the trigeminal nerve ganglion, where it does decrease pain signaling by inhibiting substance P, calcitonin gene-related peptide, and and glutamate. So that's kind of how I think about it. Is like, hey, do I really, is this someone who can tolerate one of the heavy hitter medicines, in my opinion? And that's when I offer like the localized therapy, like Botox injection, because you really don't have to, in my opinion, you really don't have to use that much. Only about 20 units is what I start off at, sometimes 15, sometimes 25, depending on how many teeth. That's what the kind of literature says to do as well. Or if they aren't on board for trying that, which is totally fine, then I'll actually offer a topical compound rinse. And that is, I have it go to a compound pharmacy if they want to try this. It's 2% gabapentin, 2% lidocaine, 2% ketamine, and 2% ketoprofen. And how I think of it is like the gabapentin is going to lessen the nerve misbehavior. Because in theory, the nerves are seizing on a micro level. That's why gabapentin, could work. Lidocaine to kind of numb the pain signals, just gives them some palliative relief. Ketamine to kind of put the nerve endings to sleep, if you will. And then ketoprofen to address any nerve inflammation, like if there's any like neuritis in there. And sometimes there is some inflammation, like a neuroinflammation associated with it. So I will offer that to them as well. I kind of start with that sometimes too, because it's super conservative, and I have them dip a gauze pad in there, and then you hold it on the tooth for 10 minutes, up to 4 times a day. And I find that that works for a lot of people, and they tend to stop having to use it over time. So they might start off doing it 4 times a day. They expectorate, they don't swallow it at all. And then they go down to like maybe 3 times a day. That's because like it's enhancing neuroplasticity. And then they're kind of going down to twice a day. And then like I have a lady now who she was doing it 4 times a day religiously. And then now she's down to once a month. And then I'm thinking she probably doesn't even need the once a month. It's just probably like a little pain flutter from something. And so it's quite amazing. I have another patient who he's doing Botox for it because he was a dentist, a little bit older, didn't want to be on any systemic medicines. And 1 dose of 20 units of Botox in the trigger point area of the atypical odontalgic pain has lasted him 9 months. And the first time I did it, it lasted 1 month. Second time I did it, it lasted 3 months. Third time, about 5.5. And the last time I saw him, he is at 9 months. And I think now he's at month 6. And I'm very curious to see, is he going to be at 1 year? But it's really because the brain starts to rewire, and it's like it does enhance neuroplasticity in this way, and it's amazing. I mean, to me, it's just incredible that I can just inject 20 units of Botox in one area that has caused this patient, emotional pain, pain with chewing, and it lasts 9 months, and you don't have to be on any systemic drugs. You don't have to, worry about any levels of the medicines changing in your blood. You don't have to worry about getting your, sodium checked if it's going to like drop your sodium, like oxcarbazepine can. So that's kind of my typical thing that I'll try for them. One other thing that I haven't quite done yet, but it is in the literature that you could do to kind of confirm your diagnosis is sending them off for a lab serum hydroxybutyrate. There's a study that showed that patients with atypical odontalgia had higher serum 3 hydroxybutyrate compared to patients with typical tooth pain. So that could be like another kind of diagnostic, thing to try, but I haven't done it yet just because, I'm going to treat them either way since they've already pretty much been flushed out through the dentist, through the endodontist, when they get to me.
Yeah. That's a fantastic thing to offer and some great results. Are there
Mhm.
certain types of patients that you see, types of demographics that are more likely to have atypical odontalgia, or types of anatomy that make someone more likely to experience this?
That's a good question on the anatomy. I haven't quite thought about that, but yeah, the literature does say that patients who are in their fourth decade of life, and typically more female, will get this, especially after a dental procedure, more so one of the more invasive procedures like extraction and implant. I think it's not as common in just like a filling or a crown, but I definitely see it more in like these endodontic retreatments and extraction and yeah, typically fourth decade of life or later on in life too, but fourth decade of life, female is the predilection there. To address one thing with the anatomy, the only thing I can think of is this condition can come on if you have other facial pain conditions like trigeminal neuralgia, right? Where 70 to 80% of the time, the superior cellular artery is being compressed with a trigeminal nerve. So if they have had that and it's confirmed on MRI, that's another maybe anatomy thing that, I could think of as if they have that. And I'm thinking, okay, maybe they are going to be prone to these misfirings of the pain signaling, but nothing really, I haven't known much of the anatomy of like the teeth or the dentoalveolar bone. I don't know if it's in the evidence, but I find for my practice, it's more of a maxillary posterior tooth. Although I have had it in definitely mandibular as well. And it's mostly posterior teeth. I've only had 2 cases where it's been anterior teeth, but mostly posterior for probably just more nerve endings are in there.
Yeah, I wonder if it's, well, for the mandible, you'd think they're closer. Posterior teeth would be more, in proximity to the infraalveolar nerve. I don't know. I mean, who
Yeah.
knows? I have no idea. That's really interesting. What other advice do you have for the oral surgeon who's seeing a patient, that has this type of atypical pain? It's not, we're not quite sure what's coming from. How would you direct the oral surgeon that's got the patient in the chair?
Yeah, I mean, I think just making sure you get some good imaging to truly rule out anything periapical pathology wise, or even like a different pathology that's like referring to pain there. Definitely
Yeah.
rule out temporomandibular disorder. So doing the full exam of like, you know, tenderness to palpation of the trapezius, splenius capitis, levator scapulae, temporalis masseter, the TMJ itself, because sometimes obviously there's the pain referred there. So I always rule out TMD with these patients. I'll always do just a very thorough exam of, where does the pain track, so to speak? Because a lot of these patients can say, okay, it starts right here and it ends right here. And I will purposely go backwards and say, okay, when does it start and end? And they're typically right on the money. So I think that if the oral surgeon is hearing them saying it's a constant pain, Tylenol, ibuprofen barely helps, which that means it's not really inflammatory, right? If it's more of a dull, could be, the burning, itching, prickling, all the type of neuropathic, I would not take out the tooth, because that to me seems pretty obvious that it's more of like a neuropathic origin, and that gabapentin, might help them there, or even like that atypical odontalgia rinse I was talking about, gabapentin, lidocaine, ketamine, ketoprofen topical compound. Yeah, definitely it's going to be an eye-opener to me if they're talking about more of this tingling, lancing, sharp shooting, and the endodontist has ruled out a fracture. I mean, for me, being oral medicine, of course, I would prefer someone to try these reversible things. You can always take the patient off the medicine. You can always stop the Botox. You can always, to make them not go to cognitive behavioral therapy before doing something that's gonna, have them be surgically irreversible and have to get an implant, and then might even make it worse, and
Yeah.
so I would say, again, it is difficult, because my average patient has had something in that location, just like these trigeminal neuralgia patients as well. I would just do like a very thorough pain history, and if you have like a neurologist that you're close with, or a oral medicine or orofacial pain specialist, maybe send it to them first and have them evaluate it, even over like a virtual call, just so that they can kind of understand like the pain characteristic before committing them to an extraction.
Yeah, for those maybe who don't have access to a oral medicine specialist,
Mm-hmm.
and would consider doing the Botox injection. So how do you know where to inject it? How does that look? How much to inject? All that type of stuff.
So it's going to be like intragingival, either on like the facial gingiva or the palatal side. And I will say, doing Botox in that area, it's not a simple squirt and you're done. You have to kind of like infuse it in there because it takes a while to kind of get through all those areas in the gums. So, I have them pinpoint exactly where the pain is. And, yesterday I had a patient, it was on the palatal side of teeth 4, 5, and 6. And so I usually do 20 units of Botox if it's about 2 teeth, because my rule is like 10 units of Botox per tooth. So I tried about 20 on her just because I was going in between the teeth. So I just did the regular Comfort Tox needle and just kind of infuse. I did like 7.5 on the lingual portion of tooth 4, and then like 7.5 in the interdental papilla on the palatal side, and then 7.5 on tooth 5, around 7.5, I guess. Like maybe it was like a little bit more than 20 units or whatever, but yeah, kind of just like bathe all the areas that the patient tells me, and that's when I like take my finger and I say, okay, tell me when the pain stops and starts. I do it in every little nerve ending that could be signaling from the pain, in that area. So I would just have the patient guide you. A lot of times, like they'll be like, "Yeah, it's this tooth right here," and then again, do your testing. Like, okay, this one. They're like, "No, no, no," and then like kind of don't put it in order so that they can guess. I just kind of inject it, and you'll see it blanch. You'll see it blanch all near like the gingival sulcus down into the vestibule, sorry, down towards I'd say like the mucogingival line. But you really don't want to put it in the vestibule itself, because sometimes patients will tell you it's like at the root of the tooth and they'll kind of point up here or down here. But because of the spread of Botox, you are going to probably get it into the vicularis oris. I always caution them that it's possible that you're going to have a little facial droop in the area, regardless if everything's going to happen or not. Because I've started to dilute my Botox a little bit differently than how I do it for myofascial pain. I do a 0.5 dilution now instead of a 1.5. I have had a lot more success with just getting it into the gums, because what was kind of happening is I felt like there was a lot of volume going into the gums, and so the rest of it had to kind of put in the vestibule, which it still helped with pain reduction. Like the intensity was better, the duration was less, the frequency was less, but they had a little facial droop. So now I'm only putting it in the gums unless they have it exactly in the vestibule, but then I always kind of tell them you might have a droop. But yeah, you just want to be careful about the vestibule just because of the spread. But I think the lower amount of saline you use to constitute the Botox, it's going to be a lot better. And you kind of just have the patient guide you on that.
And you're not using this in conjunction with local or any other types of injection.
So yeah, I do sometimes do the diagnostic block just to see if it's centrally mediated or peripherally mediated. And remember, if it's peripherally mediated, that means that the numbing will work and they're going to have, full effect of the lidocaine or septocaine or Marcaine. If it's centrally mediated, it might come back in like 2 minutes, and I've had that happen before. And it's possible. I still think the Botox can work because Botox works at the peripheral and central sensitization level, but I sometimes do a local in there. I've just had more success in it not spreading if I don't do local first. Although sometimes, in the beginning when I started kind of doing this, I found that when I gave local, it gave me more room. I didn't have to like squeeze the Botox as hard because I expanded the area in theory, but I really want a good result and like very localized. So I'm not doing the local injection anymore, but I do have them do benzocaine gel like for 5 minutes, really rubbing it really good. I know the literature says just to do 2 for like a local infiltration injection or like a inferior alveolar injection, but I have them do it for about 5. And the last 5 patients haven't felt the needle at all. So, because it's a very small needle. It's like a diabetic needle, super tiny. like probably 30 gauge or something, or even smaller maybe. But yeah, they haven't, because it's like one small area, I feel like the benzocaine jelly just does super well and I don't need to like do a local infiltration to them.
Nice. Okay. You can still do this. I mean, I'm sure you still do this when there's teeth that have been extracted and it's just gingiva there or other types of
Mm-hmm.
scenarios.
Yep, I'll do it if they had like a coronectomy, because maybe the teeth are root canaled and they want to keep it disease free, but they're nervous to extract the tooth to make it worse. I also do this in trigeminal neuralgia as well. It acts like very similarly with decreasing the pain signals, but there is one patient where I'm injecting like all around the root tips that have been root canaled. And, she's an amazing case study because she went from having so right when I started treating her, I did put her on oxcarbazepine. I know we're kind of going off topic with trigeminal neuralgia, but it's still a type of this like neuropathic pain, and she might even have some atypical odontalgia within it. But I put her on oxcarbazepine, but I also did Botox because oxcarbazepine wasn't working at first super well. Like it was like only 50% of the time, and she did have confirmed microvascular compression, but she wanted to get off of the oxcarbazepine, and so I started decreasing her oxcarbazepine, but also doing the Botox. And she went from having, 12% pain relief. And what I mean by that is in 100 days, she had only 12 days of no pain. And then she went to 24%. And then she went to 56%. And then 74%. I saw her yesterday. And now she always only had 9 days of pain in 100 days. So that's 91%. And she's only on 150 oxcarbazepine in the morning and 150 oxcarbazepine at night. And she was at 8 tablets of 150 each total, and it still wasn't touching it. So it's kind of amazing how she really has had, these therapies enhance her neuroplasticity and rewire her brain essentially to become pain-free. And I'm really anxious to see, like, in the next 100 days, how she's going to do. Will she have only 2 days of pain? And then that's when I start to decrease the Botox as well. Maybe if she got 20 yesterday, I'm going to try to give her 15 the next time, and then 12 and 10, and just see if I can get her down to 0. And then, she doesn't even need the microvascular decompression surgery or gamma knife or anything. So.
Yeah, that's great.
So I definitely will do it to answer your question in teeth that have been extracted, like the extraction sites around the tooth itself, around the dental root tip, if it's been treated, around implants.
Implant. Okay.
Yeah, and per the literature, only 3 to 6% of people will get this, even though there's a lot more research that needs to be done on it. So it's like a very rare thing, but I tend to see those 3 to 6% is so.
Yeah. For those that it's a virgin tooth, I'm wondering if I'm sure you do a thorough background in history, but I'm wondering if these people are bruxers, do they have different types of myofascial things going on that can spur this? Or do you not notice any association with stuff like that?
I do feel like, yeah, the ones that have the virgin teeth that have it, that I've, ruled out everything else, is they tend to have a parafunctional habit, so they might be like lip sucking or chewing on their cheeks, and I can kind of see like the more saccatio-bacarum or linguarum, on their cheeks on that. Their sleep partners tend to say that yes, they are bruxing at night, and so I think there is some type of like micro trauma to the tooth, or maybe the opposing tooth got worked on, and so it's changing, the occlusal relationship there just a little bit. Maybe the nerve ending is kind of spurring off because of that. That's like a really insightful question there.
I mean, because I'm thinking if they're clenching and, like in the TMJ space, we think of the pressure and seeing free radicals forming there. Can that same pressure around teeth cause free radicals in the blood vessels
Oh,
and the
yeah.
nerves and the bones? I don't know, but
Mhm.
maybe some type of damage there to nerves from that mechanical pressure. Who knows?
Yeah, no, I think, yeah, the mechanoreceptors could become sensitized. I mean, just, all of a sudden out of nowhere, really, that's why we call it idiopathic, right? It's just like maybe the nerve endings in the pulp are becoming sensitized from exactly what you're saying. Or just, again, maybe they have some type of, migraine that's sensitizing their nerves as well. And so another random tooth just kind of gets there, or type of like a type of like primary headache, maybe. Just I've just really found that when like a lot of these patients have TMD as well, or they have migraine as well, or they've been diagnosed with atypical facial pain at some other point in their life. And so it's kind of, to me, it's like, yeah, their nerves are just more subject to having that signal be amplified when it's like converting from the spinal tract to the brain and the brain stem. Yeah, I mean, probably something. We just don't know a ton about it. We're still trying to learn more and more. Yeah, that's a good thought for sure.
Yeah, this is a great topic. I think even just knowing that this is there, that
Mm-hmm.
persistent idiopathic dentoalveolar pain or atypical odontalgia is a thing is just good to have on our radar and be aware of. One more thing that we can potentially turn to for pain instead of just always thinking it has to be, a crack in a tooth or caries or,
Yes.
something in the pulp, some inflammation. So, yes, really helpful topic. I appreciate you sharing some of this. Any other comments on this one?
Yeah, I will say that a lot of these patients have maybe been to the neurologist about it, or like their primary care provider, and when they hear me talk about it, just because I've had obviously the specialized training or maxillofacial surgery as well, rather than someone with like a pure just medical and not dental background, is a lot of times the patients say that like they think that it's in their head, because they've heard the dentist say, there's nothing there. You don't have perio. You don't have infection. You don't have a crack in the tooth that we can see. They make the assumption that it's in their head. But when I tell them, no, you're not making this up. Like your nerves are just short circuiting for some reason or another. There's some type of dysfunction, not your fault. They feel so vindicated. And you
Yeah.
seem like the hero. You seem like a huge hero in their life. And like they will visibly be moved, knowing that, oh my gosh, okay, there is something wrong, even though it's not my tooth. And, it's great for us because we're not going to throw the dentist under the bus or the endodontist or, the neurologist or anything. But they really get a lot of benefit from just knowing the diagnosis. And actually that makes some people feel better. Like I've had people
Yeah.
meditate, crazy enough, because cortisol gets released in the hypothalamus and that worsens pain, and just them like kind of like feeling relieved that someone, number one, listened to them, that they like have a diagnosis that actually can make the pain better, because the limbic system isn't as involved. It's not as much emotion with it. I've had a guy like meditate his pain away. Actually two patients have meditated their neuropathic pain away, which is kind of amazing. It makes sense to me because that's why psychiatry and neurology are double boarded. There's so much interplay with the mind-body connection that I think that it can work.
That's a great point. Yeah. I've definitely had patients sit down in my chair that have said, oh, yeah, I have a pain. And my
Mm-hmm.
dentist, my doctors keep telling me it's just something I made up. It's in my head. It's like just dismissing something that I think you're right. It can make a stronger limbic response, and the pain gets worse when it's dismissed and disregarded.
Totally.
you know
Mm-hmm.
so that's pretty cool, that just recognizing it and pointing that out can even have beneficial effects on the
Mm-hmm.
the nerve circuit.
Absolutely. Yeah, exactly. And one thing that you can tell them, because I have a lot of patients who ask me, do I have to be on this medicine forever? Do I have to do Botox forever? The answer is no, you don't necessarily have to, because I tell them like, you're in this pain cycle right now because the brain loves cycles. But that's why we're gonna try and go from different angles. We're gonna try and have you do some cognitive behavioral thoughts. We're gonna have you stop worrying about it, maybe even put you in a S6 retainer for distraction, Botox, potentially in the future, hopefully not, but like amitriptyline, nortriptyline, and eventually the pain pathway, gets disrupted, and then a new neural pathway gets created, and that's what we're after. And that's what I kind of tell them. That's like rewiring the brain, because you can rewire into pain, you can rewire out of pain. which kind of relates to the whole central sensitization and enhancing the neuroplasticity to not do central sensitization, have that happen. So yeah, that's another thing I just like to tell them is you're not going to have to be on this medicine forever. It's not that you have to. Sometimes people, it is very stubborn, and yeah, they are going to be doing kind of Botox for multiple years. But to me, it's amazing that I can just inject you one time. It takes only 5 minutes to inject you, and you might have 9 months of relief, 3 months of relief, 2 years of relief. I think actually I saw one of the studies they were doing Botox and they did it 3 times every 3 months, and they stopped at the 3 times and they did a checkup 4 years later at a follow-up, and most of them were still pain-free. So that's pretty good.
This is maybe related or not, but is there any other type of lifestyle changes you have them make, diet, supplements? I mean, anything that helps with this or not really?
So I'd say anything to do with enhancing your diet in terms of getting more anti-inflammatories, more antioxidants. That's going to always help. Lifestyle, yeah, I think exercise will help. I remember being in like this medical school lecture and they say like the number one treatment for anti-aging is exercise. But I think, yeah, Mediterranean diet, 'cause that's going to emphasize, vegetables, fruits, whole grains, legumes, all that stuff. I feel like that's going to help in terms of getting minimal processed foods. The kind of just like going off of more physical activity. So at least 150 minutes per week, spread out into 3 to 4 sessions. That will help, and especially doing moderate to rigorous intensity. Resistance training as well. It's just going to help with the whole body regulation and metabolism. That's going to all kind of go into weight management. Of course, smoking cessation, try not to, do any of that, but those are all going to be supported just in general. I'd say, if I had to really think, I'd say maybe try to avoid eating super hard, chewy foods. It's going to also help with like moving TMD off of your radar as well. Just chewy bagels and steak and hard, crunchy foods. I feel like that tends to maybe create little micro fractures. And in theory, okay, maybe the nerve endings are sensing the fracture somehow, some way, and relaying that up to the spinal cord. So just trying to do everything you can to like prevent any dentistry as well. So that's why I will highly encourage like some type of occlusal appliance. Doesn't have to be an orthotic device per se, but like even like an Essex retainer can just help with like distraction, and at least you're not banging tooth to tooth, at least there's some type of material that's getting the brunt of the force.
Yeah.
Basically dental prevention. Go to the
Yeah.
dentist every 6 months or even every 4, maybe, just making sure you're doing everything you can to not put more occlusal forces. I always want to tell them like you should get if you have any tooth that's not there because you have it extracted, like tooth replacement is very important, obviously, whether it's like implant or bridge or partial. That's going to just even the occlusal forces and not have one side get more. That's going to kind of help prevent anything.
Okay. Nice. Well, awesome. This has been a great topic, and I think a helpful thing for all of us to be aware of, to think about. If there's listeners who have further questions, are you okay if I put your contact info in the show notes?
Absolutely. I'm very passionate about this topic, so I would love, love, love it.
Excellent. Cool. Well, thank you so much. I appreciate you doing that. We usually end with some rapid fire questions. The first one is, what's the best book you've read in the past year?
Best book I've read. Well, you're going to think I'm such a nerd for this yet again, but I have it right here. Oral Facial Pain. This is the guideline for assessment, diagnosis, and management, the 7th edition. Yeah, I really love to be like so upfront with my patients and knowing all the research and literature, and I'm just like passionate about it myself because I think I've had some of these conditions too. I listen to more, I guess, podcasts rather than read books. And I hear Min Lab podcasts a lot.
Oh yeah, that's good stuff.
Yep. I just did the 16-hour one on sleep, and that is I can't remember his name right now, but he's a PhD and he goes through everything from, how to improve quality of sleep, quantity of sleep, sleep chronotype. And if we have a couple minutes, it's kind of cool to know, but that apparently, everyone has a sleep chronotype. You either are a extreme morning, evening or extreme evening chronotype. And he says it's almost as genetic as eye color, like once you're an adult, because it can kind of change. But the extreme morning are people that their body naturally wants to go to sleep at like 8 p.m. and get up at 4 a.m. The morning chronotype are people that want to go to bed at 9:30 p.m. and naturally wake up at like 6 a.m. The evening chronotype are people that want to go to bed at 11 p.m., naturally get up at 7:30 a.m. And the extreme evening chronotype is people that want to go to bed like 1 or 2 a.m. and their body naturally wants to get up at 9 a.m. And, it was really interesting to hear about it because he says, the world caters to morning people, right? Like work starts 8 to 5. And a lot of people get discouraged and they get called lazy when they aren't morning people. But he says it's just as hard for someone to work out at 6 a.m. as a evening chronotype, comparing that to a morning chronotype trying to get a workout in at 10 p.m. And where you're best off doing your work and like you get the most done, it's totally different from all the different people. So like extreme morning people probably their most like proactive in their work at like 12, whereas morning it's like maybe 2, whereas evening it's more like 5, extreme evening like 8. But it was so cool, and I felt very vindicated because I'm personally an evening chronotype, and I do a lot better like in the evenings. Like I work out in the evenings. I'll go like on a midnight run sometimes, and I felt like very vindicated when he said, "You don't have to feel like you're lazy, if you're not a morning person. This is your genetics, and it kind of makes sense because." Some people's parents are morning people, some are night owls, and you can kind of pass that down in a way.
What does he mention? A difficult thing is when you have a husband and wife where they're very different, and one is like, for example, I'm a morning person, my wife's an evening person.
Okay.
And so naturally she wants to stay up later. It's very hard for me to stay up late. If it was up to me, I'd go to bed at 9 p.m. every night,
Mm-hmm.
And it just creates extra challenges there. But maybe just knowing that this exists could help you in your relationship. That's interesting.
Yeah, it could. I mean, I think you can use it to your advantage of like, okay, well, you can drop them off, at school early and I'll pick them up later or whatever. And I did kind of ask in like, can your chronotype change? Like, can you change your own chronotype? And it takes a lot of work, but in theory you can if you just like kind of work towards it. But if you don't try, you're just gonna stay, your chronotype.
Yeah.
Which again is fine, but I could see how I think that a lot of relationships have a hard time with the sleep because not everyone wants to go to bed at the same time, and you might feel neglected if your partner doesn't go to bed with you at the same time, but people can work through it, and at least they know, oh, it's a genetic thing. It's not that like my partner's choosing not to go to bed with me. Their body doesn't want them to.
Exactly.
For their own sake of health.
Awesome. Well, this will help me. I'm gonna go tell my wife that it's genetic, honey. This is not my decision.
Yes, there you go.
Very good. Well, thank you, Hayley. I really appreciate you today explaining all this, and I think this will be valuable for our listeners.
Absolutely. Yeah, I'm very happy to share. And again, anyone can contact me, and hopefully this helps people in their practice.
Yes, I'm sure it will. Well, thank you so much. I'll put all the information in the show notes, and hopefully we can do another episode sometime.
Yeah, I'm always down. Thank you so much, Grant.
Yes, have a good rest of the day.
Yes, you too. Take care.
Okay. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayoralsurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.